Well, good morning, good afternoon, and even good evening to all of you who are in today's Skills for Health thematic ecosystem. These are one of the um, great opportunities we've been able to do to pull in input from across the globe on topics such as skills for health. And in particular, this ecosystem has been looking over the last over 18 months now at a number of different areas around the whole issue of skills in digital health. We've all been listening to lots of people who've made a lot of noise about the need to upskill, increase skills, increase the amount of workforce, as well as skills for carers and patients and citizens. And this is one of a number of ecosystems we've been running in partnership with RMIT in Australia and also our colleagues in South Denmark ecosystem. We've looked at skills needs for carers and citizens, frontline staff, carers, and also management. And today we're looking at a very, very important topic within that skills framework, which is around skills for colleagues who are involved within the field of digital health, around informatics and other areas that aren't either one side ICT or health only. So we're pleased to welcome you to this session today. I'm going to hand over to my colleague Karen in Australia, who's going to give an introductory message and also a note of acknowledgement.
Thanks very much, Andy. So an acknowledgement of country is something that we do in Australia. Is to be able to acknowledge the traditional owners of our land. So for us, our First Nations people, our Aboriginal Australians and our Torres Strait Islander peoples. So what we do is we acknowledge them as the traditional owners of the land. So where I am today, it is the Wurundjeri people, and it's the Wirrawong and Burrawong language groups of the Eastern Kulin Nation. But I also live down in Tasmania, which is the Palawa people of the Luthawita country. So I pay my respects to the elders, both past, present, emerging and future. And I'd like to acknowledge that these are the traditional custodians and ancestors of the lands and waters across Australia, where today I'm presenting from. Now, it's really excited that today we're going to be talking around this specialist digital health workforce, because this is the topic that I'm really passionate about. And I'm really glad to be joined today by one of my strong research collaborators and my mentor, Professor Kathleen Gray, who's also going to talk a bit more about who this specific workforce is, as well as a panel of amazing presentations that you're going to hear today, including from the EMEA president, Jack Lee. But first, what I wanted to do was just to give some context about what we meant by the specialist digital health workforce. And the reason why is because as we started discussing what this session was all about, it became really apparent that the language that we use to describe who this workforce is changes from country to country. And that in fact, a lot of this country, and this wasn't new to people like Kathleen and I, is actually a hidden workforce. Now, Kathleen and I adopted this term hidden and some years ago, and it's to use to be able to describe these, you can see in blue. It's the areas of health informatics, the workforce that's working specifically digital, and then those with roles relating to data, information, and knowledge. Now, Kathleen is going to talk a lot more and unpack this a lot more today, but I just wanted to provide this high-level summary about who this workforce is. And this triangle you can see was one that was developed here in Australia to try to categorize, because, I'm a health information manager, we like to categorize things. And so we're sort of saying this level 3 is your frontline staff. So these are the people providing direct patient care. In fact, we talk about what the role is focused on. So level 3 workforce are those that are the frontline carers or frontline workers, where the primary focus of their role is on caring, providing care or providing support. We did a session on frontline staff in 2022 and talked about what were their needs. The second level is that these healthcare professionals and administrative and manager type roles where they need to use data and information to inform their role, but their role is still very administrative or management or service type driven roles. And again, we had an entire session last year which focused on the roles of the health service managers and etc. We did also have another session in late 2021 that focused on the patients and carers because they are another important part of this workforce. But now we reached this top area, and that's what today's about. These are the people that work in roles where their primary function of their role is related to data, information, knowledge. And that's quite often acquired through all of these types of functions of a role. So it's, the people that manage a medical record department, or that they might code some when I say code data, it's two different ways. It could be coding to be able to create a software program for a health service, but it might also be clinically coding data using ICD codes to be able to report it to the World Health Organization. So we call them in Australia our coding workforce. It might be health informatics roles where it's about being that translator between a technologist or an engineer and the clinician to be able to support implementation or management or maintenance of a system. It might be clinical documentation improvement, and we know that's a role that's really evolving and emerging in today's digital world. So this is the sort of workforce where the primary role isn't necessarily providing patient care, and it's not managing a service. It is focused purely on being able to create or manage or work with that data or that information or that knowledge. And this is what we call the specialist digital health workforce, or the hidden workforce, as I described before. I'm going to leave it there because I don't want to steal too much of the thunder from Kathleen's presentation. She is going to talk a lot more on this topic today. And instead, what I'll do is I actually like to introduce, hand over to my colleague, Caroline Strudwick, who is going to introduce our first presentation.
Yes, thank you, Karen. So we've done a few of these events, as you've already heard, and we always structure them in the same way, where we start first with what is the need for skills within the target group that we're working with. Then we'll move on to what does good look like, and then in the end, how can we match the needs and the solutions? So we will start with what is the need for this particular part of the workforce when it comes to skills. And to start with, we will, as you've already heard from Karen, we have Kathleen Gray with us today from Australia at the University of Melbourne. So Kathleen, over to you.
Thanks very much. Just fiddling with my settings. I'm going to talk in very general terms about the need, and then if time permits, dive into the details of the people whom we know have met this need in the past, as distinct from where we need to go in the future. So if you don't mind, I'll just share my screen. Is that visible for everybody? Yes. Good. Okay, good. Let me just put it on presentation. Sorry, what happens when you're at this time of day is messages start coming in from all of your teams. So I'm just getting competing signals here. Let me just go through them this way. So you have to think about the health workforce as a workforce that is distinct among those in the economy, in being highly professionalized and highly regulated. And there are many reasons for that. Some of those reasons can be ideological, some of them can be political, some of them can be sociological, some of them can be economic, some of them are simply accidents of history. So It used to be that in the Middle Ages and really up until modern times, in among all of the professions that we refer to in society, there were only 3 learned professions. And one of them was the law, and one of them was divinity, and the other one was medicine. But since modern times, I guess if you like to say late 19th century, our idea of what professionals we need in health, why we need them, and how we create them and manage them and regulate them and make sure that they make health a better thing than it otherwise would be, that has been quite a recent phenomenon. So we need to remember that when we're talking about what for some people might be the view that this is an innovation, oh no, not another specialist group in the health workforce. But think about your answer to this question. Why do we need specialists of any sort? It has not historically been the case that we have had so many specialized professions in health as we have now. So what I'd like to do is actually focus on this idea, and it's a bit of a sociological take on the question, but I think it's very useful for us to come out of our bunkers and remind ourselves of health as a social system. That we have this idea that to have a responsive, responsible, safe health system, one where we manage the risk to human life as well as we possibly can, and we uphold the Declaration of Human Rights around the individual's rights to health and national government's obligation to uphold that. We hold that as well as we can do, that we subscribe to this idea of professions. And of course, this is a definition of a professional that I'm just going to unpack in terms of, ask yourself, is there any other professional group in the health workforce that can do what hidden specialists can do, or that holds the ethical standards, is schooled in the body of knowledge, and has the preparation and will to apply this in a particular way? Ask yourself, what group can you think of in the health workforce that can do this in light of health information and health information technology and health data as we now see it in healthcare around the world? And that's basically my case for why we do need specialists in this workforce. So if we turn to the idea of ethical standards, in fact, not only in routine healthcare practice, but also in health research, which gives us the evidence base to practice in health, there are serious ethical issues. There are serious matters of ethics that need to be attended to. And if, name the health profession of your choice, whether that is nursing, medical, allied health, I guarantee that group will not be across the detail of the ethical standards that are required to look after health data, health information, and health knowledge in this risk mitigation kind of way. So I want to also to illustrate that many health professions would simply be unaware that there is a code of ethics for health information professionals. And it's not that new. It's been around since 2016, and it builds on work in informatics, which has been going on for well over 50 years. And that there increasingly is recognition that there need to be ethical standards observed when we are using health data, health information systems, and managing health knowledge in health research. That this is also something that is beyond the scope of practice, beyond the training and professional development that is provided in any health profession apart from the specialized ones. So moving from ethics to the idea of a body of knowledge, again, I without expecting you to read any of the fine print on this slide, I'm sure people can supply it to you later. I would stress that the idea of the specialized body of knowledge of health informatics that underpins digital health has been really well thought through over a period of many years. And in fact, only in 2023, in February, was published the most recent iteration of the body of knowledge and the topics that go with it. And you can see, again, that this is not an assemblage of knowledge and skills and expertise that you would find in any other health profession. And I've used the left-hand side of the screen here to illustrate from a more of a med tech industry perspective rather than a scientific informatics perspective, the body of current emerging technology knowledge that one needs to have in healthcare somewhere. Somebody has to have a handle on this and have an overview of it, be able to manage and govern decisions in health about it, that's coming out of technology developments. And I've used the Gartner organization's hype cycle of the many technologies that are emerging in healthcare provision and where they are on the Gartner cycle of just emerging, bobbing out for a while, and then establishing plateau of, we're using this now, it's routine. This changes every year, and you cannot expect any of the other health professions that we know of to be monitoring this, thinking about how to make decisions about this, and indeed how to invest in it carefully, because this is not only a risk to human health, it's a risk to the economic sustainability of national healthcare systems. To make the wrong decisions here can be a terribly expensive proposition that can cost investment in other areas of human health. So it's a very big responsibility. It's becoming bigger all the time. And we need specialists who can take responsibility for this. This is my last slide. And this is the idea that as a specialist in this area, you're not acting for yourself. You're acting with a sense of purpose about the interests of others in the health sector. And most national governments would have some version of what I have on the right side of our screen here, which is Australia's Health Performance Framework. In other words, we have a mostly publicly funded health system. It recognizes many social determinants of health. It recognizes many factors in the status of a health status of an individual. And it has some parameters around what it expects to get for our national effort and our national investment of people and energy and infrastructure in health services. And that ranges from equity through to continuity and through to sustainability, and of course includes safety and quality. This is something that somebody in the health workforce needs to be able to have the specialized knowledge and expertise to hold health IT to account for. In other words, if our health service is going to invest in a new system, a new virtual care approach, a new AI-supported decision support framework for clinical decision-making or for surgical procedures, how are we going to be able to account for how we contribute to the performance of the health system by doing that? Somebody has to be able to take on that kind of evaluation, answer those questions on behalf of the investor, the nation. And that is so also at the global level. I think many people in the health workforce would feel quite capable and competent making decisions and understanding the value of the electronic medical record system that they might have implemented in their own health service. But what we know now about information technology, information management, data analytics in health is that this is a global concern. And if COVID taught us nothing else, it taught us that we need to take a global approach to how we manage health data and how we leverage it. And for those reasons, I would argue we very strongly do need a specialized workforce in this area. And I would just note that I've undertaken a scoping review that Karen well knows with colleagues that identifies many of the different names that we have given in the past to the people who have been the specialists in this area. There's a body of literature going back decades now about the specialized workforce in managing and governing health information, health data, and health knowledge. And what's very interesting is really the variety of names that can be given to that. Sorry, I'm just going to try and find my screen for that. Can you see that one? The variety of names that can be given to this role. This is a non-standard role compared to other health professions which are more established, but it has existed over the years and it will continue, in my view, to be recognized as a specialized area of work that's increasingly needed as health systems are increasingly dependent on new technology. So I'd probably like to stop there. I'm happy to take questions or hand over to our next speaker.
Thank you very much, Kathleen, and thank you for underlining the need for this specialist workforce and their skill set. I think we'll take questions after the next presentation, maybe for both of you, and or actually towards the end of the event. We always do this, so thank you very much. Next up, we have Anne Wales from the Digital Health and Care Innovation Centre in Scotland, who will also talk a bit about the needs for the skills of digital health specialist workforce. So over to you, Anne.
Thank you. I'm just trying to share my screen here. If you can just give me a moment.
Absolutely.
No problem. Take your time, Anne.
Thank you.
We also can't see you either.
Right. Can you see my slides coming up now?
Yeah.
That's great. Okay. So thank you very much, everybody, for the invitation to come and speak to you today about some of the recent work I've been doing around the specialist digital health workforce. There's two recent developments I want to share with you. One is about learning and development needs for use of algorithmic and AI tools, and the other is a competency framework for users and providers of decision support. Both of these developments build on some extensive workforce development analysis that was carried out by my organisation, the Digital Health and Care Innovation Centre, and two of our NHS health boards in Scotland in 2019 to 2020, looking at the learning and development needs of knowledge, information and data staff to support transformation of health and care. So I'm just going to share the two most recent pieces of work with you. First one is this learning needs analysis around using algorithmic and AI tools. For this piece of work, we carried out a rapid evidence review. We had 10 stakeholder interviews with leaders in the knowledge, information and data fields. We had a national questionnaire survey and a total of 11 focus groups across 2 workshops. Key findings were, in summary, the immediate need for learning and development in this area. One of the questions, or question marks, I should say, that was put over this work initially was that AI-based tools are still relatively immature in the NHS. There aren't many examples of them being in day-to-day use. But what this study showed was that knowledge-based algorithms, i.e. algorithmic tools based on validated guidelines and research, are already in widespread use. And there are many machine learning driven initiatives that are getting to the stage of evaluation for rollout in practice. We came up as a result of our needs analysis with this pyramid for a learning framework. At the base of the pyramid, you can see we have foundational level knowledge and skills, basic knowledge and awareness needed by all staff groups. Then at the intermediate to advanced level, we have facilitators and creators of algorithmic and AI tools. And this is where that specialist knowledge, information and data workforce tends to sit. Facilitators are staff who support the embedding of these tools in practice. Creators are those who build the tools, find out about user needs, and act as go-betweens between the users and the software developers. And then, of course, we have the actual end users themselves, who may be health and care practitioners, but also can be managers of services. Moving up the pyramid, through continued practice and engagement in this work, of course, some of the facilitators, creators and users will become experts, thought leaders and authorities. And then at the top of the pyramid, we have senior organizational executives, people at director or associate director level, who exert a huge influence on how use of these tools is progressed in the organization. We did want to stress, though, from all our consultation, that leadership is essential at all levels, right from the foundational ground level up to the top. It's not the prerogative only of these senior organizational executives. And a final point I should stress about this pyramid is that it needs to apply not only to health, but also to social care. It was very clear from all the needs analysis approaches that we used that the greatest emphasis so far has been on developing these tools and these skills in the acute sector in hospital settings. We need to extend that into primary care, the community and social care. So we do intend to be proactive in reaching out to support learning needs in that wider context. Here's just a few examples of the kinds of learning needs that we came up with. At foundation level, there were really 4 key categories of learning and development needs. These core concepts: safety and legislation, the evidence base, and ethics and bias. Moving up to the intermediate to advanced levels, creators and facilitators who fall into the specialist digital health workforce category had a much wider range of learning needs. I've just highlighted a few examples here, but I'm happy to share the full report for anybody who is interested. And at the intermediate level, there are also additional skills for users. For example, being able to share information about these tools and their outputs effectively with patients to build shared understanding for collaborative decision making. And we also identified, as you would expect, a range of soft skills that are essential to these creator and facilitator and user roles, such as problem solving, creativity, and leadership. The learning needs analysis I've just summarised there fed into, was one input to the next stage of work, which has been developing a competency framework for providers and users of decision support systems, or DSS. Again, I'm happy to share the full competency framework with anyone who's interested, but in summary, there were 21 generic competencies identified. These are relevant to all users of decision support and all providers of decision support. And you can see they fall into these 5 categories, which very much mirror what we found in the learning needs analysis. At the provider level, here we are talking principally about those specialist digital health workforce roles, particularly the knowledge, information and data workforce. And for the provider competencies, we used this knowledge into action cycle as the organising framework for the different categories of competency. So we grouped the competencies under each of these headings: defining needs, sourcing and generating evidence, design and delivery, implementation, improving and adapting. There were 43 additional competencies over and above the 21 generic competencies that were relevant to providers of decision support. The great majority of these competencies related to creator and facilitator roles as identified in the learning needs analysis. Important to highlight that by evidence here, we mean evidence from data sources, big data sources, as well as evidence from published knowledge and evidence from experience. So it's a broad church of evidence that we're concerned with here. That's really just a quick summary of the most recent work. It does now provide us with quite a solid foundation for moving on and developing some learning opportunities, both for the wider workforce as users of decision support and algorithmic and AI tools, and particularly for the specialist knowledge, information and data workforce, who we know have been perhaps somewhat neglected in the past around their learning needs in this area. So thank you very much, and happy to answer questions when we get to that point. Thank you.
Thank you very much. As Anne said, she'll be happy to share the competency framework, so let us know if you would like to see more about that. Also, you might have noted in the chat box while Anne was presenting that Adriana has put in a link to a Padlet like we've done in the other events. You're welcome to put in your thoughts on what the needs are for this specialist health workforce. So if you go to the chat box, you can find a link to it and put your comments in there. You're also welcome to share any questions that you have for the presenters in the chat box or in the Q&A, and we will then get back to them later, and we'll get back to also the results of the Padlet. So thank you. Just put anything in there if you want to bring your perspectives in. And otherwise, we'll be ready to move on to the next section of today, where I'll hand over to you, Karen.
Great, thank you very much. So for our, sorry, I've lost my notes. For our next presentation, it's actually a recorded presentation. So we have Beatrix Leal, who is the former president of the Brazilian Health Informatics Association, who is linked to EMEA. And we have a recording from Beatrix that Adriana is about to play.
And before we do, just a bit of background. This is, we've had input obviously from our different ecosystems in the past year, but this is directly as a result of the work that we're doing for our Global Health Connector Partnership. So we've been looking at 4 key areas within that Global Health Connector Partnership. And one of those, again, is skills for health. So alongside colleagues from DHI, this is where Anne's come from, we've also brought in expertise from across the globe for several of our themes. And this is where Beatrix's input is coming in from Brazil. So over to you, Adriana.
Good morning. My name is Beatriz de Faria Leão. I'm a medical doctor working in São Paulo at Hospital Sírio-Libanês. I've been working in health informatics since 1986 when we founded the Brazilian Health Informatics Association. And I had the privilege to be a president for more than four times. On this more than 35 years of work, I've been working in the academia, in the government, and in the private sector. So I guess I've been very, very lucky. It's really an honor to be part of this panel discussing such an important issue as the skills for health information and health informatics capacity building. This is a team that lives in my heart since the beginning of my work. So in recent years, Brazil, as many other countries, has been going through this digital transformation in health and requires, of course, a lot of human resources qualified. Brazil has a national e-health, digital health strategy published in 2020 that has 7 priorities, and one of them is building the workforce for digital health, and that is a challenge for the country. The Brazilian Health Informatics Association has done in 2022 the second revision of the landscape analysis of where we are and which are the programs we offer and what are the competencies that are being taught in these programs. Our landscape analysis showed that we barely have 69 different initiatives in training people in health informatics, from which only 17 are graduate programs. And of these graduate programs, most of them are certification programs. We only have 7 master programs and only 3 doctoral programs. So we are not being able to build and form our researchers and experts in the area. And I think this is a major challenge for the country. We found out on this landscape analysis that there are different denominations for the same specialty. More recently, the new programs are using the term data science and health informatics. The programs that started earlier still use health informatics, and the ones in between use now digital health. But the point is that there is no a minimum curriculum for the area. So each of these institutions has created its program according to the experts they have. So the program has one or another emphasis. Aware of all these difficulties, SBIS started the discussion of what are the competencies we need. And we have used as a guideline document the second revision of EMEA recommendations on education in biomedical and health informatics. And of course, we have used the 6 axes, the the recommendations published. The fundamental principles of health informatics, health sciences and services, data science, information and computing, social and behavioral sciences, management science, and specialization in health informatics. We have delivered a questionnaire to all members of all these 69 programs across the country and other invited experts to identify for each level, basic, intermediate, and expert, as the EMEA recommendation states, which would be the competencies needed for each of those levels according to the EMEA areas. We have just compiled these results and we are delivering them to the Ministry of Health that has gladly created a new Secretary of Digital Health. We believe this Secretary will be able to organize the efforts toward the development and recognition of the area in the country. We don't have health informatics recognized as a field of knowledge in our research agencies or our Federal Council of Graduate Programs. So this is an urgent need that we recognize the area so we can fund it properly, we can have students, and we can develop more programs. So as I said in the beginning, there is a lot to be done in the country. I think we are in the right path following the international recommendations, and we are willing to work together with many other countries and other initiatives to develop our area. Thank you very much. It's been an honor to be here with you. Thank you.
So we pay our thanks to Beatrice for that presentation, and thank you very much, Adriana, for sharing the screen. Our last presentation today is from Jack Lee, who is the president of the International Medical Informatics Association. Jack is actually presenting from HIMSS, which is in Chicago, so it is nearly 3 a.m. in the morning, and extremely grateful that he is here to present for us. Thanks very much.
Thank you, Karen. Karen, can you see my screen? Okay.
Yeah, I can see it.
Just a couple of slides. First, it's my great pleasure and honor to be participating in this panel. Even 2 a.m. in Chicago, I'm still quite with high spirit. But because there are only 7 minutes, so I'll just give a quick introduction of what EMEA is about, and also talk a little bit about digital health adoption, barriers and solutions. So this is a little bit about myself. I'm a dermatologist and a professor in biomedical informatics, also elected fellow of the American College of Medical Informatics, the International Academy of Health Science Informatics, and also the Australian College of Health Informatics. I'm also the editor-in-chief of the BMJ Health and Care Informatics, which Karen is also one of our deputy editors. And I'm the current president of the International Association for Medical Informatics. So a little bit more about the EMEA, or International Medical Informatics Association. If you only Google EMEA, it takes you to the International Association of Medical Interpreters. So you probably need to get a little bit more keywords in there. It's established in 1967, a formal NGO under the World Health Organization based in Geneva. And it's also the largest international medical informatics organization with more than 60 member societies from all different countries. Our immediate past president was Dr. Sabine Koch from Sweden, and I'm the current president. There are 6 regions in this involved in EMEA, so from Europe to Asia Pacific to Africa, Middle East, North America, and South America. And Brazil will be part of the South America region. And also, as Kathleen already referred to, EMEA has been working and publishing a code of ethics in health informatics and educational guideline and certification. EMEA also provide a on-site certification process for graduate programs on health informatics. And also EMEA has more than 26 working groups and special interest groups there's a very diverse topic, from standards to even, specific area like psychiatric informatics. There are 5 official journals. I'm not going to name them one by one, but you can easily search them on the internet. And one of the major activities that EMEA is doing is a biannual World Congress on medical informatics, or we call it MedInfo. And it happens that many of you may already know, it happens that Sydney will be hosting, which is Australia, will be hosting the this year's MedInfo in July. And the next one in 2025 will be hosted by Taiwan, which will be in Taipei. So all of you are welcome. The last one, MedInfo 21, is the only virtual MedInfo we had because of the apparent reason of COVID-19. And we do have the Dr. Tedros from WHO giving us a opening speech, and we have participation from all over the world. So we all know, actually, we all know there's potential benefits for digital health adoption. And the reason I want to, go through this list is because for all the digital health workforce, if anybody can contribute to any of these, then there's a value. I mean, there's a reason why we need these task force or workforce to be in place to help us improve treatment efficiency, saves time, which is actually the lack of time is actually a reason for a global healthcare workforce burnout. Okay, you see burnout almost in every medical conferences, as a major topic. We're joking that if you go to any medical conferences in the world, and the two rooms that's packed with people, one is about AI, the other is about burnout. So these are the hot topics around the world, and because time is really running out. And increased patient satisfaction, now it's become one of the payment standard, the payment index for some countries around the world. Increased patient safety, of course, we've been through this for a long time. Improved diagnostic ability, daily productivity, physician-patient relationship and communication. And of course, within our organization, interpersonal communication with colleagues, because the hospital or healthcare organization, it's the only place in the whole world that you have people with more than 20 different licenses working under one roof. And as you know, people with licenses, they're very specialized people, and they talk their own language. But then if you put 20 or 30 different kinds of people with different licenses under one roof and expect them to communicate flawlessly, which is very difficult. Ease the burden for chronic patient care and cost saving. So these are obvious benefits. However, there are a lot of barriers as well. Again, if you ask any doctor, why don't you use the system we just developed? The answer is, oh, I don't have time for that, right? And if I have to learn it, increase my workload, and I have to go register here, I have to create an account, it increased my administrative task. And I don't have this resources and financial difficulties. The hospitals say they don't have the system, they don't have the hardware, software, and space and human resource to do that. And of course, if the insurance do not reimburse, then it's hard to implement. And of course, there are not enough trained staff. And using AI, of course, now we use a lot of AI. There's a danger of overdiagnosis or a lot of false positive. Increase the misuse and misunderstanding of digital health technology, especially when we are in a world that we're overwhelmed with fake information and misinformation and disinformation. An increase in health disparity due to limited health literacy, trouble patient data privacy. Every time we talk about big data, then people talk about privacy. That's a showstopper. Resistance from physicians and a work culture of refusing. It might not be refusing innovation, but we do adopt innovation very slowly. So potential actionable steps will be, now we have more evidence-based digital health solutions. We have more practice guidelines to support things, availability of specialist training, improve the quality, safety, effectiveness of digital health technology, facilitating law regulation. I'm not going to read every of them, but things like user-friendly interfaces, it's been talked about for forever, and we're still using like, kindergarten level user interface in our hospitals. After we spend hundreds of millions of dollars, we're still using these funny 1960 user interface. And there's not many of them don't have very good incentive structures. And of course, patients' positive attitude and preferences regarding digital health solution. Patients' adoption usually become one of the reason why we want to do more digital health and innovation-oriented work culture. So I would conclude by this slide that there, in the IOM, and now it's the Academy of Medicine, their recommendation of 5 core competencies need for healthcare professionals. So besides, patient-centered care, disciplinary team, evidence practice, and quality improvement, now it's been utilizing informatics. That's why I think this is so important and has to be in every joint, in every connections of the whole healthcare network, in order to make healthcare really go into the next century or next generation. Thank you.
Thank you very much, Jack. So Adriana's shared in the chat the second Padlet that we have for this session. We also encourage you, if you've got any questions for any of our speakers, to put that in the Q&A so that our speakers can respond to them. What we might do is just pop back to the first Padlet. Caroline, did you want to talk to that one?
Adriana, are you able to share it?
Yes, wait 1 second. You should be able to see it.
Yep.
So there's definitely something about looking into the future and how we create learning pathways to ensure that we can meet the needs that come in the future. That's a very good point. What are we missing? Information about what gender gaps there are in the specialist digital workforce in comparison to other areas. That's also very relevant. And a predominantly female workforce. So that's kind of related to the other one I see.
Did any of our 3 speakers that we still have on the line, so Kathleen, Anne or Jack, want to talk about any of these posts or anything else related to what are the needs that we're missing? I see Kathleen's
so that was me responding to what's the gender balance here by Karen, as you well know, looking at the stats from our 2018 workforce census of the specialist workforce that we ran in Australia. And indeed, predominantly female workforce, which is possibly, arguably why it's not more predominant, but that's not an argument we want to pursue here right now. But also, definitely we don't have the data on this at a global level, and it's a perfect opportunity for Karen and myself to flag that we will be running this same census in conjunction with the MedInfo conference in Sydney, and it will be globally open. So we hope that if lots of people know about it and lots of people who count themselves in complete the census, that we will all be able to share much better data about the structure of this workforce now and identify the gaps. And I also just while, perhaps if you refresh your Padlet, you'll see that I put in a response to the question about what are the jobs and what are the pathways, and that comes from a HIMSS resource, which analyzes current jobs and pathways, and it's not necessarily over the horizon. It's not the workforce that we'll need when all of healthcare is run by, robots, but it's certainly a contemporary take on what we found when we did our scoping review with many weird and wonderful job titles. This is much more established according to HIMSS's global analysis. Thanks.
And if I can just add on the 2 points that Kathleen's just made, with the census, we will share further information about that with Andy and Adriana closer to when the census is running, which is during the month of July. And anyone and everyone that's on the call today can certainly undertake that census and conduct it in their own countries, and then access the data from that census to be able to inform you about that workforce within your own country. With the predominantly female workforce, that was when we looked at all of the roles across hidden. And so what we find is that roles that are related to paper medical records and classifications are predominantly women, and health librarianship were women. But when we looked at roles that were related to health informatics and health IT specialists, it was actually 55% females and 45% men. So really shifted that balance the more we moved towards digital type roles. Jack, you've got your hand up.
Yes. So I'm not really very familiar with the result of the census, but is there a like a pay scale type of information for this or the specialist job? One of the reason that our hospital could not get good IT people is that in Taiwan, all the best IT people, they went into the semiconductor integrated circuitry business because they pay IT people 3 times more than we paid them. And so it's really about, the pay scale is, the skew of the pay scale is one of the reasons that we cannot find enough or very high quality IT people that could actually change the digital health ecosystem, in a healthcare organization. The UI, the kindergarten UI user interface that I was joking about. One of the reasons is because we only got these, newly graduate computer science students, and then after a few years, they will switch to a job that pays them much more. So that's so how do you respond to that kind of a challenge?
Yeah, we did capture remuneration data, and again, it depended on what type of role the person worked in, what area, whether it was within a hospital or primary care, so GP, general practitioner, or it might be with a vendor. So that sort of varied it. We also did some analysis looking at whether they had just a undergraduate or graduate entry qualification, or if they had a master's level qualification, the amount of time they took between their undergraduate and their master's, and then what that meant for remuneration as well. What Adriana will share shortly in the chat with everyone is a link to the old census website. We're currently, so it's shifted from the University of Tasmania to RMIT University, and we're just going live with the census webpage next month. So I can't share the new one, but on that old one, you'll be able to see there is a project reports section, and that has a number of different reports on it, and papers and such. You can get some of this information from.
Just We've got Anne and Sana on from Scotland, from DHI. What are you picking up about this in Scotland? I don't know if Anne, you're still there, or Sana.
Sorry, think about what needs we're missing. Is that the question, or? So I think there's such a raft of needs. It's quite hard to just summarize in a few sentences, but some of the key areas are the ones I guess I highlighted in my own presentation around development and implementation of algorithmic and AI tools for decision support and for other purposes. One of the key types of role that we uncovered in some of our workforce early work was what we have called a knowledge translator role, i.e. somebody that sits at the interface between understanding the needs of users from digital information and knowledge, and the context was an understanding of the environment in which these tools need to be implemented. So they've got that understanding of how to facilitate implementation. And thirdly, the other kind of circle, if you like, in the Venn diagram is that they interface with technical developers. So they sit right in the middle of the three circles: the user needs, the context of use, and the technology development, and have quite a unique role in being able to work across these three domains, understand each of them, and communicate with people in each of them. So that knowledge translator role is one that we do see as quite key for the future. I don't know if Sana wants to add anything to that. If Sana's still there, maybe not.
Yeah, she's still there. Sana, we've made you a panelist. So if you've got any input, you should be able to speak now. And George, I think obviously we've got George Margellis on the call. Sana, I don't know if you can hear us.
Yeah, sure. I just found the microphone. No, I don't think there's much that I can add to Anne's input there about the specialist workforce. I guess there's a lot of specialist areas coming up now, like lots more areas are going to be digitalized, like pharmacy and all these areas, but that's maybe not part of this conversation. But it seems to be becoming more and more common, prevalent that we need more specialist digital skills or digital capabilities as more and more areas become digitalized.
Okay, it's helpful. George, I see you're on the call. I don't know if you've got any input from your side. No. Okay, back to Karen.
That's okay. We might. Oh, here we go, George. No, George, for some reason, it's still coming through muffled. We might also just jump to the other Padlet as well, because we've got some really great comments coming through there around the barriers. So, lack of visibility. Interesting about the siloing as well. Health professionals say they're specialists and not really health professionals. IT professionals say they're specialists and not IT professionals. The hype around misinformation and that people doing self-learning. I very much agree with the outdated formal training pathways as well. And is formal training the way to go? Is that the way to actually develop capabilities and in general? But then how do we what we saw through some of the census data is a lot of people were moving into these specialist roles because they just got the job and not necessarily through a training pathway. And I think that's also what that first post was about. And that then what Kathleen was talking about in her presentation, then we don't have that quality happening throughout, and you know, quality of training provision as well as the other area. And then hang-ups about language versus hang-ups around the state of digital health adoption versus excuses for not adopting. Did any of our speakers also want to talk with any of these posts, or just on the topic about barriers in general?
No, but George has put a comment in the question Q&A.
Oh, great. Thank you. The capacity health informatics and clinical skills recognized will enable clinicians to play a greater role. Thanks very much, George. And actually, if I can jump to Jack, changing your hats, Jack, to your academic one. Jack was one of the very first universities in the world to actually put a specialist training program through the EMEA accreditation process. So was there any, you know, experiences from that you're happy to share?
Yes, we do have a certification review and certification on site back in 1990. No, sorry, it's 2006, I think, for the master program, and then for the PhD program. Well, I think the most of the effort were that we try to find a middle point. I mean, the challenge back then is that for us was to integrate the bioinformatics program and the clinical informatics program. And actually, during that process, I moved to another university where I was trying to integrate a bioinformatics program and a public health informatics program. So that's how, you know, diverse and also from different origin that this, now we call it digital health. Back then is the informatics, or from the academic side, we usually call it informatics. But there are so many different types of informatics, and they originated from different disciplines. But they all end up helping biomedicine and healthcare in this whole continuum, and they borrow methods from each other, right? So our challenge was to integrate these two programs and how to make these different faculty members understand each other's research and try to, you know, being able to mentor students together, graduate students together, and have collaborative projects from within. After a few years, we were able to collaborate and obtain more collaboration from healthcare industry directly, either from biomedical biotechnology companies or from healthcare organizations like teaching hospitals, because we work together. So back then that was our challenge. Yeah.
Yeah, thanks very much for sharing that. And it's interesting, the post that's just been made. If we change the word digital health specialist to social care worker, both subject to silos, both are hidden workforces. We're seeing similar sorts of patterns across them. Wonder if we even have thought of health informatics in social care. Yeah, there has been some things looking at that, and that's why we talk more broadly around health and care. But that's a really great post. Yeah, no, that's a good post.
Me being Mr. Grump, I think, you know, when I talk to social care organizations, they feel sidelined in this conversation because we've got a vision that this is someone sat in a hospital, in a lab, in healthcare, not social care. And yet, if you think about the amount of data that's there, hidden, not picked up on, not used in social care, and start plugging in some IoT devices and start picking up raw data, all of a sudden, there's an enormous amount of value from somewhere we don't even touch, don't value at all as an organization, or as a topic.
And actually, yeah, to follow up on that, the lacking or the incompleteness of social care actually leads to a hole in the healthcare system that require more healthcare resources afterwards, because we could not do this 1% in social care. We have to, pay 10 times more after the fact that the damage has already formed to somebody's health. And we see that as a clinician, I do see that from time to time, quite often, actually.
And then to take it even one step further, what about these roles that are currently part of this workforce that we're now starting to see automated? So, my go-to example is always the clinical classifications or medical coding type roles, which, as we see greater integration of terminologies into our systems, so SNOMED terminology, for example, well, then that's going to increase automation. So what do we do with that workforce? Do we, we can't just make them redundant. So how do we retrain them in areas such as clinical documentation improvement or, quality or data analytics type roles? And Kathleen, I saw you come off mute as well.
Yeah, I was going to pick up on Jack's point about the sort of bad feedback between informatics in clinical care and social care. Just to say that PhD student I'm working with right now has got a lot of attention for pointing out that this exact issue in case of mental health clients and patients of services, where clearly there are really strong connections between social care and clinical care, and the electronic medical record systems by and large simply aren't designed to address these, nor are the record systems of social care services. So that's a really, pertinent example. But I guess to this, what's going to happen to the workforce if they don't specialize or step up in this area? I think, we are certainly seeing some professions that are disappearing, and coders and hospital librarians are certainly among them. And those people who want to pursue a career in an increasingly digital health system are really needing to go out and grab with both hands some new areas of specialized expertise that may update what they've got, or may extend them in some way. And I see that very much in the work that I've done with the National Health Librarians Group in Australia, which 10 years ago, well, we were calling it e-health then, of course. They had no idea what that meant, and now are actively recognizing health informatics certifications in their professional development, and are, volunteering to be on leadership committees around digital health planning and so on, because they can see a role for themselves and their skills, but they see that they have to put themselves forward and upskill to move into the new roles. And some workforces, this will happen, in other workforces, it will not.
Great, thank you, Kathleen. We have one last activity to do for this session, and just noting we've got 14 minutes left. What we might do is just wrap up this part of the event and thank our three speakers that are here with us today. So Kathleen Gray, Anne Wales and Jack Lee, and also to thank Beatrice as well for her recording. And move into the next part, which I'll hand over to Caroline to just introduce. No, okay, I'll be doing it.
No, it's okay. I was going to start with just saying kind of what have we been through in this journey of the skills for health, and then we'll go on to, and then you can introduce it. Yep. So I've kind of looked back on what happened to the skills for health thematic innovation ecosystem, and it started back in April 2021, where the ECH Alliance hosted a workshop, and the European Commission presented the Pact for Skills. And then in September 2021, we had the first ecosystem event where we looked at the needs for skills and the case studies for 3 different target groups. That was citizens and carers, healthcare workforce or frontline workers, and then this specialist digital health workforce. And it was obvious that there was a lot of interest in this and a lot of need for more information on each of these target groups to treat them separately. So in 2022, and then moving into 2023 with this particular event, we've had 4 different events with 4 different target groups. So the citizens and carers, the frontline workers, the healthcare managers as well, because we realized that the managers are an important part of driving the digitalization of healthcare, and then the specialist workforce. And what we've always done is have the same structure of talking about the needs for skills, then the best practice examples, and then how to match the needs and the solutions. So there's been a lot of participants in all of these events, and we'd like to thank everyone for participating and giving their contributions and having these discussions with lots of people from different parts of the world, lots of good people. And then the important part is now, what's next? How do we take this further on and move onwards from here? Yeah.
Yeah, thanks very much. And you know, our thanks also to Andy and to Adriana for their support with over that, 18-month period. You know, the events have been well attended, but also the recordings that Adriana puts up on the website. We know some coordinators tell us that they actually will hold an event and play these recordings at those events or promote the recordings within their ecosystem. So it's having a really far reach, not just those that turn up for their live events, but, the recordings. But, in our planning for this event, Caroline and I sort of went, well, what's next? We've looked at it through these 4 different lenses, but where do we now take the skills for health thematic ecosystem? And that's where we were wanting to hear from you about where to next. What do you want to explore? So Adriana has shared a Padlet where you can post your ideas on there. But, we're really interested in what are those real key critical things that are coming up. I think maybe if we can reflect on some of the things that we've seen through, these 4 different sessions that we've held, we're seeing, I've just seen literacy and capabilities come up time and time and time again. That's probably one of the ones I've taken away from these. Caroline and Angie, what about you?
Certainly from Caroline's point of view, I'll let Caroline speak.
No, you're already going, so keep on going, Andy.
Oh, so some of the conversations we've been having within the Global Health Connected Partnerships say, okay, how can we broaden this wider? So that's where we've got the involvement today from colleagues from Brazil and from Scotland, and certainly the conversation there we've had a little small stakeholder group within the Global Health Connected Partnership that's looked at, where are there curriculums that we can share? Where can we get cross recognition for different skills from country to country? How can we address issues of validation, etc., for training? And I think certainly there's interest from colleagues within the Global Health Connected Partnership to bring in more evidence, more content, and most importantly, more opportunities to collaborate. Because sharing stuff's great, sharing's caring here, not caring, but caring. But sharing is great. But so what? What are we going to do? Where is there some collaborative projects? Where can we better work together to maybe mirror adoption in one country into another? So we're seeing great content and input coming from India. We've seen already, and we've showcased in previous episodes of this, where we've brought in content from Africa as well. But obviously we're trying to broaden that and broaden the area we're focusing on. So I've already put in the Padlet when I was mid-typing and trying to talk at the same time, which, as you know, I can't do. But so the idea of multitasking, where is there some shared, is there a curriculum already developed in certain countries? Can we share that? what practical steps can we get validation done? I don't know if Sana, if you're still on the call, you've got any input on this as well. I know you've been discussing this with colleagues from WHO and also from Brazil, George Magellan as well. So I'll leave it at that. But certainly, I think there's so much more to do. Social care for me is crying out for a whole session looking at it, and potentially even informal carers as well. To go back to that one, but I think the collaborative piece needs to happen a bit more. And also something about where's the funding for this? Where's the cash? I'm stopping talking. I'm going to mute my microphone.
What's been interesting as well is I see there's a note around the collaborative international certification, coach tells. I think that's a great idea. And then, you know, something else that I've certainly seen evolve a lot more, you know, from the ECH Alliance is that that partnership across the ecosystems, you know, for example, Horizon funding and such. So there's other areas of opportunity as well. And I'm seeing a more calls coming out through Horizon that are related to, you know, the broader skills for health area.
Yeah, we can also, for the collaboration, we can definitely agree that it's good. We see that we have the same challenges across the countries, across the region, so we need to collaborate on this. And we've also presented a couple of times from our Deliver project, which is funded by Erasmus+, and that is one place to go to get funding for some of these projects, where we've had 4 countries in Europe working on it. But just this can be taken even wider, because it's not just these 4 countries that need it. So we do need to look at collaborative opportunities. I completely agree on that. We will also put in the chat in a minute the latest update from Deliver.
Great, thank you. And then also just on the point, you know, Andy's put in their social care, but I've also wondered whether there is an opportunity to, and Andy might shoot me for saying this, but you know, crossover between thematic ecosystems. So for example, what do we need for skills for health within aging, for example?
I can
I should write that one down, don't I?
That's fine. I think it could be an ideal topic, and I think George and I have been discussing the idea of an aging ecosystem, Australia-wide, but also globally. A thematic ecosystem target in this area is there for the work, and I think skills within that will be an ideal topic, as it would with the topics we've got on many other of our thematic ecosystems, such as continence, such as women's health, etc., etc. So I think there's crossover all over the place.
Well, I think we've got quite a few things that Caroline and I can now go away and work with Andy and Adriana to be able to see what we can share.
And we're bringing input from the Global Health Partnership again, because I think it just adds to that mix. And certainly, as we've seen with both Jack and Beatrice today, it's been really, really great to see, you know, a wider helicopter view of what's going on.
Perfect. Andy, can we hand over to you to wrap up for today?
Well, I'd like to thank all our speakers. I'd like to thank both for staying up and or getting up early. Speakers from across the globe, which has been great to do today. Thanks also for the colleagues from RMIT and from South Denmark, for our ecosystem, for co-hosting these events and helping us to create this content and get some action as well. Certainly, we will be coming back to you with obviously recordings from today and resources that we've seen in the chat function. We'll send out, and we'll chop up some of our content as well for you to share after today, as well as ideas around topics for our next gatherings. The idea behind ecosystems, of course, is that they're permanent. So we keep looking at different topics because there's so much we can cover on this. And if you think, you know, this is just a small area, just think this is the European Year of Skills. So there should be much more attention on this, I think, from the health world. So, and finally, obviously, thank my colleagues Adriana, Ines, and Iman, who've been great in terms of all the back office support. Thanks to Jack, Beatrice, Anne, and Kathleen as well for taking the time to come today and I think drive the content. So thanks very much for that.